afternoon, Chairman, Co-Chairman, and fellow orthopedists. It is my honor to be discuss for you about the topic of orthobiology, whether we have a consensus on joint preservation. My name is Nattaphat Srisuwat from Ramathibodi Hospital, and my advisors are Assistant Professor Nattaphat, and I want to express my special gratitude to Special Advisor from Chiang Mai Hospital, Assistant Professor Dr. Phuvapong Nimkinglat. The osteoarthritis is a degenerative progressive disease that causing from deterioration of biological structure, mechanical properties. The ideal medical treatment should have the ability to delay or even halt the process. Initially, the patient should be treated by initial conservative means, while the surgical intervention should be serve as a last resort. Osteoarthritis starts from compromised articular cartilage, which could be caused from mechanical force from instability and mechanical injury to cartilage or subchondral bone. On the other hand, can be caused by inflammation process from metabolic dysfunction or immunodysregulation as a pathological chemical stress. This eventually lead to cartilage degeneration. Current conventional treatment is mainly to impede the disease process, but does not regenerate the joint structure. This video will walk you through the potential bioactive injectable agents. We're going to be scoping around the hyaluronic acid, PRP, BMAC, and a little bit of stem cells and growth factors. First, the hyaluronic acid, or HA. The endogenous HA could be found in cartilage and synovial fluid. Its main function is to be the lubrication, scrubbing for free radicals, regulator of cells activities. So when we inject the exogenous HA, it may not fully replace the characteristic and activities of endogenous HA, but it may relieve pain. The mechanism of functions could be the synthetic polysaccharidoglycan or GAGs, anti-inflammation action, limited lymphocyte mobility, and viscoelasticity maintenance. Currently, there are numerous literature, including systematic review meta-analysis that widely address benefit of HA over placebo. However, the well-known guidelines do not have an agreement on this. We have two guidelines that have weak to conditional approve the use of HA, while the ACR and the AAOS recommend against. The previous edition of AAOS claimed that the diluting effect of HA may be due to the different preparation of the HA. So the latest edition of 2021, they did their own meta-analysis on the specific molecular weight and preparation. But even so, they found that when they only include the low bias study, they still did not find the data that reached the clinical relevance for pain or functional outcome. The latest RCT agrees on the AAOS. Teach-ups in 2023 performed 4-tail RCT of comparing PRP, HA, steroid, and placebo, and did not find any differences. This may be due to the issue of molecular weight. 2008, Raymond found that statistically different in pain and functional outcome score when comparing high and low molecular weight. This has been aligned with another meta-analysis from Altman 2016, which have a favorable outcome of HA of molecular weight over 3,000 kilodalton. Recent meta-analysis by Phillips et al. Confirmed the surpass effect of higher molecular weight when compared to lower. But however, this has been disagreed from AAOS. They claim that when they include the study and made their own analysis, they did not find the significance of pain and functional outcome score. This may be due to lower number of study and the analysis of criteria of inclusion. Apart from molecular weight, another property is the cross-linking. This cross-linking of the HA probably increase the viscosity property, increase joint residence time, decrease joint friction, and may interact with the receptor of the cells differently. The recent RCT point out the statistically different between cross-link and non-cross-link, and with the outcome in favor of the cross-linking. However, the value was so small that it may not contribute to the clinical significance. Again, the AAOS says that when they include only two high-quality studies, the cross-linking property of the HA may not show the difference in outcome. Next, another guideline that disapproved of HA is ACR 2019. The ACR, however, only cite one systematic review claiming that will limit trials to only low risk of bias. The effect of the HA was approached zero. This is the cited reference. This reference actually, when include all of the literature, as you can see, the favorable outcome is trend toward the HA. But they eventually claimed that most of the studies have low level of evidence. In the doubt of efficacy, however, HA is overall considered safe with low incidence of 8.5%, local adverse effects such as pain, swelling, arthralgia, which subsides within few days. When comparing to other agents versus steroid have a burst effect of pain relief within 2 weeks and then gradually worn out. Conversely, HA produces more obvious effect over time. And when comparing PRP, some of the RCTs such as Chloe in 2016 did not find a significant of the outcome. However, most recent meta-analysis that compare HA with PRP shows quite impressive outcome of significantly better improvement of WOMAC score, pain score, and IKDC score at 12 months. So this leads to our next agent, the PRP. The PRP is a highly concentrated platelet through the process of nitrification, which composed of rich platelet growth factor, theorized to achieve chondroprotective anti-inflammation process and immunomodularity effect. This has been used for sport-related injuries such as tendon and ligament, and some of them have clinical trials that show the improvement of the functions such as the tear of gluteus medius, but obviously not the draw over elbow, right? But the precise mechanism was unclear. But the osteoarthritis current guideline do not have much evidence on this agent to recommend against the use of PRP due to lack of convincing evidence, and two did not even mention it. WAOS 2021, the father of indifferences, claimed a mixed result of the PRP when comparing to placebo. But this time, the latest double-blinded RCT agreed with WAOS on non-significant difference in functional outcome or pain score when compared to placebo. This mixed results of PRP in the literature may be due to heterogeneity of leukocyte concentration difference on preparation. The leukocyte is known to be the important factor of pro-healing factors such as cytokine and key enzymes. However, leukocyte rich may exacerbate osteoarthritic pain, while the leukocyte poor, of course, have less adverse effect, but also the lesser efficacy. Contradict to the theory, the actual network meta-analysis clinical trials shows the functional outcome are just slightly in favor of the leukocyte poor PRP. But again, in contrast to the meta-analysis, the head-to-head RCT when Yalodrumis 2020 demonstrates significant better improve of WOMAC score in the leukocyte-rich PRP, but not for IKDC score. Head-to-head RCT by Martino 2022 called for similar clinical outcome of IKDC when compared both of the leukocyte concentration. So for now, this issue still be controversy. So the future direction of PRP is to narrow the heterogeneity of preparation among the literature, and this matter was actually generally mentioned in MIBO, or Minimal Information for Studies Evaluating Biology in Orthopedics. Next is the BMAC, or bone marrow aspiration concentration. Interestingly, the first two agents was focusing on improvement of pain and functional outcome score, but due to the mechanism of containing mesenchymal stem cells and parenchyma effect, this agent theoretically have the potential of self-renewal capacity. Due to scarce of evidence, all of the four guidelines do not mention this BMAC yet. The preclinical study showed macroscopic and histological improvement of OA compared to placebo, and this is even without scaffold. But clinical study shows otherwise. The prospective RCT by Shapiro did not detect the BMAC efficacy over saline injection. But overall, when include all of the clinical trial of 18, found generally improvement in pain and functional outcome score. So the conflicting of result may be due to the harvest size of bone marrow, the quality and quantity of stem cells, the age of the patient, and the bone marrow starting volume and centrifugal device. But why go through all this invasive method of bone marrow aspiration when you only got just 0.001% of mesenchymal stem cells, when you can inject the stem cell itself? The major lineage of musculoskeletal cells is mesoderm. So this time, the main stem cell of interest is going to be mesenchymal stem cell, which is a multipotent stem cell that we have the ability to differentiate into mesoderm cell lineage. The other one is induced pluripotent stem cells, which possess even more differentiating capability to any cell line. The induced pluripotent stem cells, or iPSC, was first described by Shinya Yamanaka group, initially first described in 2006, that the somatic cells can be converted back into pluripotent stem cell by using transcripting factor and re-encoded by 4 genes. Generally, the somatic cells could be collected from urine, peripheral blood, and dermal cells, and then re-encoded back into pluripotent stem cells. Currently, iPSC not only just used in orthopedics, but have been studied in many regenerative medicines such as nervous system, respiratory system, visual, and circulatory system. But there are no iPSC on osteoarthritic clinical trials yet. Just preclinical studies show the ability to produce highly light cartilage in vitro. So the clinical trial is soon to come. Next is mesenchymal stem cells. The mesenchymal stem cell can be harvested from umbilical cord, bone marrow, and adipose tissue, and then they're going to be harvested, cultivate them in the laboratory, and re-injected into the joint. The mesenchymal stem cell show promising results in preclinical study. Interestingly, while the alternative agent focusing on pain and functional outcome, the mesenchymal stem cell therapy actually shows the improvement in MRI imaging in one study and even provide the histological regeneration of highly light cartilage in another study. Current clinical trials of mesenchymal stem cell have already been proven safety in phase 1, show efficacy against placebo in phase 2, and even comparable to PRP and HA in phase 3. But again, stem cell literature face the heterogeneity problem. The optimum dose of the mesenchymal stem cell is on debate. Another factor that affects the cell's quality and quantity are cells preparation and cells origin. So the future direction is to uniform the literature that has been concerned and addressed by international expert consensus on cells therapy communication tools by Delphi method, or short for TOSSM, which encourage the literature to provide the following information such as donor, origin tissues, preparation method, exhibit cells, characteristic, and size of delivery. Last, the growth factor. This is the attempt to seize the pathological chemical stress in the joint, subclassify into a cartilage-driven endotype, synovial-driven endotype, and bone-driven endotype. Due to the short amount of time, this mostly has been addressed in only phase 1 and 2 clinical, so it's still a long way to come. So overall suggestion of clinical practice guideline. We have 2 clinical practice guidelines that approve the use of HA, while the other 2 was conditionally to moderately against, while 3 of them against the use of PRP, and all of them did not mention stem cells, growth factor, or BMAC just yet. In summary, level of evidence right now, we have several RCT and meta-analysis on HA and PRP, while we are producing more and more clinical trial on BMAC, stem cells, and growth factor. Current guideline, some of them have approved the use of HA and against the PRP because of lack of evidence. Maybe it's going to be changed in the future, and they do not have a say on BMAC and stem cells just yet. At some point, there are clinical trials that approve the improvement of pain and functional outcome in all of the agents. But the only agent that have the potentially regenerate highly light cartilage is the stem cells. According to the burden, HA and PRP have relatively lower burden comparing to BMAC and stem cell, which you have to go through the process of bone marrow aspiration and cells culture in the laboratory for several weeks. All of the injectable agents was generally considered safe except for stem cell therapy, which have the potential to create the teratogenic cells. And last, and is the most important, when you look at the literature, you need to look for the heterogeneity. For example, for HA, you have to look for the cross-link property, a molecular weight, synthetic method. PRP, the centrifugation device, the leukocyte concentration. For BMAC, it's the size of harvest, amount of bone marrow, and the age of the patient. The last, cells origin, doses, gene expression, autologous, and allogenic. In conclusion, to date, even though we have promising results in animal model, the clinical trial have not shown the desiring regenerative effect of bioactive agents just yet. So the uniform information in clinical trials must be conducted in the future research. Thank you for your time and attention.
Thanks, that's a very wonderful talk. So I have some questions regarding your talk, okay? So first is that you mentioned about intraarticular hyaluronic acid that helps releasing the glycosaminoglycan, right? You mentioned that. So what's the mechanism of really stimulating the glycosaminoglycan? And second is, what type of glycosaminoglycan that the body release, is it like a chondroitin sulfate, the one with the long arms of the GAG, or is it like the keratin sulfate, which, osteoarthritic patient have?
First of all, as you say, this is the bioactive agent, so it has the potential to influence the cells. According to my research, I found that this HA not just only have improved the viscosity property of the joint, but also interact with the cells by the receptor of the CD44, which is activate the cells to produce more of the GAG and proteoglycans. But you're asking about the type of the GAG and proteoglycan. I did not specifically study on that, but I think it's going to be a high link change of polydisaccharide. I think it's the hyaluronic itself, but it might be also depends on the molecular weight HA that you inject into the joint.
Yeah, still a long way to go. And one more question is that, so in which case that you won't prefer the use of PRP? Because it seems like PRP seems to have like a good evidence with maybe like acceptable disadvantages, I don't know. So in which type of patient or in which situation that you prefer not to use PRP and shift to, say, like a steroids?
At first, we have to go back to the conservative treatment because all of the guidelines mention that this is never been the first line of the treatment. So you have to select the patient that did not have the entail of the end-stage osteoarthritis and do not respond to other conservative treatment. So it's going to be the second or third line of the treatment. So that is somewhere in between. And that's first for the election of the patient. And next, comparing to steroid and PRP, the steroid actually have the obvious improvement of pain, but the PRP show much longer period of improvement of pain and functional outcome score. So I'm going to be discussed because the evidence is not so obvious. If you want to relieve pain immediately, if you have like the inflammation and you want the rapid effect of the injectable agent, you probably use the steroid. And also, if you at your center have the ability to produce the PRP, and then you discuss with the patient of pro and cons of the usage of PRP, then you probably can use the PRP. And that's Max.
Thank you.
Regarding to the intraarticular HA injection, it has the function of the viscose supplement, and another function, as the Ajahn Mant point out, that the visco-induction. Based on the evidence exists nowadays, do you recommend that which molecular weight have the more function of the visco-induction?
You're asking about which molecular weight that I prefer, right? Actually, it has been numerous literature that prefer higher molecular weight of more than 3,000 kilodaltons, but this has been differences. But the actual endogenous HA have even more than 6,500 kilodaltons, so I prefer much more molecular weight. But I have to be aware of the adverse effect that come along with the higher molecular weight.